Please tell me if you see my screen now.
Yes, we can see.
Okay, so I go straight forward to the presentation. So today I will introduce a few insights on simulation and training. As you said, I'm involved with this company, Upsurgeon, as a founder and CEO. So I'm working with the University of Milano Bicocca as a joint professor, and we are doing this joint collaboration within a private reality in technology and a university where I work. So the problem is very clear to all of us. Despite the neurosurgery is a niche, we suffer from poor training sometimes or poor exposure to specific situations. And so we still practice on patients and cadavers. And numbers are quite impressive. The numbers, the size of the problem, if we go to low or high income countries. In the low income countries, we have a problem of quantity, and in high income countries, we have a problem of quality of education. Let me say that when we come to technology, the intraoperative technology, we are in the 21st century, but when we come to the way we transfer skills to the new generation, we are still in the 19th century, I would say, because we need to reinforce the way we monitor the progress of the residents and provide new opportunities to practice. So today, we practice on patients and cadavers, and it's objective that today we have no metrics. There's no objective metrics today. If you look at me, you have no idea if I'm able to operate or not, to specifically do a procedure or to manage a complication. And this is something we would love to know personally ourselves for our safety and for the safety of our patients, of course. And this problem affects big markets as well. So what is happening, and Mirza gave a very nice introduction on what is happening. I love the descendants. Robots are here to stay. Technology, AI is here to stay. So in 10 years, everything will be different. And these revolutions are in front of our eyes in other disciplines, from sports to aviation. No one of you will get a plan and knowing or hearing the pilot, my main pilot saying today, good morning, the takeoff today is practiced by a first-year resident. You wouldn't get this plan probably. So this is the cultural paradox. We accept that the first-year residents start practicing, and it's okay. It should do, and it has to do, but the price is too high. The error on a patient is too high. I apologize if I would mention some cranial surgery aspects, because surgeon and my activity started from cranial surgery. I'm mostly focused on cranial, and even if I work a lot on spine in my early career. So yes, Arjun, when we talk about simulation, what is simulation? We think simulators, but simulation is a situation. So we can simulate an intervention on a rat, and this is the concept. So don't stay focused on a simulator itself. Think bigger. Understanding that any practice on anything is a simulation, even a glove, even a rat. So the important is not where you practice, but to practice. And there is an evolution of training today. We are moving from a circumstantial training, so random training. So the more I stay in the hospital, the more I enter the rooms, the more I have a good mentor or good fellows, fellows, the more I can practice. But today we are moving to an intentional practice. We need to create systematically the ability to expose residents to specific procedures. So any residents has to do specific things and manage specific situations. And this is not something that we are inventing. No one is inventing. This was already an existing knowledge on other disciplines like neuropsychiatry, because we are talking about the way we learn. So psychologists already described that we need to be exposed to specific skills, specific practice in a specific manner and in a specific timing. So if we want to practice a perineal approach or a spine procedure, and we think that we can do one cadaver lab today and then another cadaver lab in 1 year, there's no we learn generally, and we lose any possible progress. So understanding these things, we have the first problem. How can we create a situation where a resident is in front of a real case? And so this means that we need to have something different than our patient, because I may not encounter a specific complication in my career, and the day that I encounter it, that will be the first time. So this is a randomic way we train and we learn. We need to create the mix with the cadaver and the mix with the patient, including simulations, meaning practice on every possible scenario, not just simulators. But what I want to say is simulation is not replacing cadavers. Simulation is not replacing anything. Simulation needs to become additional moments of training for residents and possibly to prepare to cadavers. My first cadaver training course was a disaster. I was a first-year resident. I did 2 cadavers that I could do on a simulator. That's the concept. And we are also aware of the understanding, I mean, the perception of residents today, because if we see surveys that we see on the literature, we see that all residents understand this problem, and all of us understand this problem because all of us have been residents. And anyone, I mean, the majority agree on what is lacking more, and education in terms of hands-on is the most important part. So we are moving from an era where we thought that surgical training could be done on cadavers only or on animal only, and we are moving to a moment where we start believing that there are alternatives. So today, probably the best combination, which is a traditional concept, is the mental training, the manual training, and the mentorship. But the tools now are increased and improved. So we are talking about, we can have virtual reality for mental training to understand the virtual, but it's not enough. We want to move our hands, our practical on cadavers or anything else, and then the mentorship. This is still absolutely important. So when we talk about AI, in my opinion, this cannot and should not replace the mentorship. I would say the mentorship is the final moment where I am already almost good, and with mentorship, I can be perfect, let's say, even if perfection doesn't exist. Let me share how we started using simulation, first of all, to create the first step. The first step was to create exposure to procedures. So these are pictures and videos from courses where we use simulation to replicate with realism, also the emotional impact to the situation. And this is important. Realism is not just to make a show, it's also an emotional impact to be there, to forget that there is a simulation and to experience all the difficulties, the depth, the tissues around, etc. I give you some view also on a bigger and better situation. This is an example of a collaboration ongoing with Stanford and Harvard on a study on anterior cervical that we hope to publish soon. This is the situation, very familiar. There is the head of the training program at Stanford. There is a resident. There is instruments on the table. There is a realistic stuff on the screen. This is an anterior approach. So the situation is what we are simulating, not just the procedure. And this is not a cadaver lab. This was a center, a room, was not a lab only for cadavers, even if we could use cadavers in this room, but you could do this in every single room. And what is going on in that specific simulation is what we see in this video, just to tell you the level of where we need to go. Of course, cadavers have no pathology. And for spine, this is critical, but I would say probably it's more critical for cranial surgery. So we can still do that, make a good practice on cadavers, even if there's no pathology many times, or there's random pathology. Carotid pulsation is an example of how we may have also the sensation and the training of understanding the position of carotid, and for the first time a tissue may pulsate. So the attempt is not to create a sawbone, a more sophisticated sawbone. Sometimes here the goal is to give additional moments in parallel to a cadaver or possibly a patient with a pathology. And this is an example. And what we have done with this technology and how we reached this, we used the methodology where we needed literature and doctors. And then from this, we created a digital and a physical archive of elements, thanks to a close work between a scientific team of neurosurgeons, in this case, and anatomists, and a development of digital artists and engineers. And then we started combining these things and create the situation with technology. But this is just the first step, because let's say these simulators are, let me say, stupid. They don't say anything. They don't give us any information. So I don't know what is happening, if I'm learning or not. And that's the second step where we are. This is another example of spine, just to tell you let's go to also to other levels of spine, but we are still working on tissues here, on the realism. And again, this is still the first step. So is the, let's say, the environment where we need to train, but now we need to do the second step, measuring abilities and measuring performances. So let's talk about this. Let me just say that obviously, even without data, it's nice to see how this technology can create opportunities in countries with limited facilities. In 3 years, we've been able to organize 45 free courses in low and middle income countries. Despite the pandemic, we started publishing the results. So we are talking about also social impact in terms of saying, okay, here in our countries, in many countries, we can talk about robotics, AI. In other countries, probably there's a lack, and we are increasing the gap now between, the stage of education in different countries. So probably the effort is not only to progress what is here, but also to progress what is still a bit behind in terms of exposure to specific procedures. So it's important to use simulation also in this sense to create new opportunities and to evolve neurosurgery in other places. Let's talk about data. I'm sorry if I move again, as I said, to cranial, but just to show the methodology and the concept. This is an example of a simulation for cranial where we did the clipping, where we have a lot of, let's say, details. And this study has been published with Harvard, demonstrating the importance of data. And so when we talk about data today, it's still a data that we collect. So we did surveys, we did observation on video, so blinded observers that evaluated videos of the performances. And we noticed an improvement after 6 weeks of training on clipping aneurysms and the other procedures on cranial. So the goal was to understand, does this data make an evidence or make a difference? And the answer is yes. So in the literature, there are other experiences of other companies, other universities trying to use even other technologies to create evidence on what data could be. And this is another example on measuring forces, how an experienced surgeon used the hands and used the instruments. And of course, we are talking about specific data. So in this case, of course, on a sensor, and the difficulty is to say, okay, this is the data, but how can we have a picture, a bigger picture to understand, okay, from this data, what does this data mean? Is this an expert or not? Are we improving or not, etc. But let's start again from the beginning. Let's start understanding how we can collect data. So these are a few examples. Another example, very, very interesting in my opinion, is sensorizing also the instruments. So understanding how we manage a bipolar forceps and understanding if there is a difference, but also if there is any marker of talent or improvement. And sometimes it's very interesting to say, like in this study, that the amount of force may identify specific stratification, specific layers in the study. So there was evidence in this study that analyzing specific parameters in the use of the forces, you would identify at least the very roughly the stage of education of the trainee, of the person that was using the instrument. And this is very interesting. And again, another example on sensorized gloves, how you use your hands and how you put forces in tissues. And again, understanding something more on your profile. And again, the goal would be to integrate all these things. And at some point, the second step is to collect multi-factorial data. So from anything, put everything together and start to understanding and giving a picture of what talent is or what your progress is. And of course, sometimes some study identified also different evidences, identifying even how we learn or how we go back in our learning curve. And I finish with this idea of a study that we are bringing forward. And again, I'm sorry, it will be on cranial, because the path of our experiments start from cranial and then move to spine. So the next step will be applying this evidence also to spine and to keep improving. And this example is on how we can also collect a new kind of data, which is the sensorization of the tissue itself. It's something that you cannot do on a cadaver. something you obviously cannot do on a patient. I would say is an additional data. It's still not the AI able to tell you you're doing well, you're progressing, you're doing this error again. But it's an additional data that we didn't have. I mean, what happens in the tissue, what happens in the tumor? And this is an example just to show you sensorizing, in this case, the orbital surface of the frontal lobe to expose the skull-based structures with the trajectory on the carotid and the optic nerve. And the system is able to identify stress over a specific threshold and giving you an idea. Of course, we are talking about an additional data that doesn't give you a complete, let's say, overview of who is operating or how is the learning curve of the operator, but it's an additional information that we should try to integrate with the rest. So that is the goal. And the goal at some point is that we could have a considerable amount of data in order to start ending a bit more from this and having more evidence. So sorry, my presentation will slow it down a little bit. So in this specific environment, we are going to add specific tasks like the dissection of the PMI arachnoid. How do we sensorize this? First of all, it's a challenge to simulate the arachnoid, but we have done some improvement, and we are using specific electronic sensorized 3D printed sensors that are thin sensors that you don't even see that are in the tissue. So the stress of the tissue can be measured around. So the point is to be specific with our instruments and focused and micro surgically skilled, not just surgically skilled. So we need to reduce the stress around. And these are the list of the, let's say, the skills and the tasks that we are trying now to implement in this kind of experiments to understand what happens and the kind of data that we can collect. At some point, the amount of data need to bring us to patterns of recognition of the skills and the improvements and also giving personalized feedback. We are all different. If you take 10 residents from 10 different schools at the end of the cycle, they will be completely different one from another because they have different chances, different days, different mentors. So the goal is not to standardize like crazy. We don't want anyone the same of another. The goal is at least to have common parameters to understand what is going on, well, to understand where we are in our path. Because again, we are still too much dependent on where we are, in which center, which mentor, which day, which situation. So there are too many factors that are limiting our possibility to expose all the residents independently by all these factors to the same or at least a similar amount of situation where they can practice. What is our final goal? Again, I showed you it is on cranial, but imagine this on spine also, because the path is absolutely the same. We are working with virtual reality to give you, let's say, a real-time understanding on forces on your instrument. We are doing a nice study in Milano Bicocca with sensors also to understand the heart rate of the surgeon and understand how your feelings change, how your emotional impact change, because training is also training on a complication and emotional control. And it's something we need to learn and come to you through some way and a user experience. We have seen obviously augmented reality through microscopes, etc. We are talking about here another possibility using visors, using virtual reality to have this like real-time feedbacks. Obviously, the work is still so much, and there is a work of collaboration with other colleagues around the globe. There is so much things that are rising up now, so we need to be able to connect and share improvement and progress to integrate all these things.